I have spent my entire career in health equity medical education and specifically focused on implicit bias recognition and management. Implicit bias are the unconscious mental associations we make about others based on our lived experience. Black patients have worse outcomes than white patients, in some ways attributable to physician implicit bias. So what we did was we made these simulations with actors and then had physicians interact with the actors as if they were real patients and look to see what are the behaviors that lead more towards error as opposed to excellence. By identifying those behaviors, we're able to inform our skills-based intervention to help us have our best clinical skills to take the best care of patients. My current work focuses on acute coronary syndrome, so an impending heart attack. And there are, unfortunately, tons of studies on that Black patients have worse outcomes in diagnosis. We were able to quantify the association of medical decision-making on the physician subjects in our simulations with racial implicit bias. And so what we found was for white standardized patients, these are all actors, right, in simulations. So for the white standardized patients, the physician's implicit bias didn't matter. For Black patients, the Black standardized patients, as your pro-white bias or anti-Black, depending on how you look at it, unconscious implicit bias increased, then your medical decision-making scores got worse. So you were more likely to diagnose a stomach problem than a heart problem. Through an iterative process with 3 team members, we identified behaviors such as empathy statements, proactively explaining sensitive questions, things like using jargon, explaining the diagnosis, treatment plan, et cetera, all different behaviors, as well as interruptions, looking down, looking away, et cetera. And then there's about 10 to 12 standardized patient behaviors that are just clues for us to be able to then look when the standardized patient said, for example, that he does smoke cigarettes, what did the physician do? Because we can analyze that through the software. And so you're looking at verbal utterances, nonverbal behaviors, and then some standardized patient behaviors to be able to develop a rich picture of what the actual interaction between these 2 humans look like. And then thankfully, we can run statistics with this fancy software to quantify it and try to build a scoring instrument. We all want to take the best care of patients we can. Nobody's intentionally hurting anybody. But if we said, be more equitable in your diagnostic process, what does that mean, right? And that's why we're taking all this time to look at these behaviors and find the inflection points of what are we doing when we go towards the heart and the diagnosis, and what are we doing when we go towards the stomach diagnosis in this particular case. And we learn from our patients that when we make an assumption, because we're humans and sometimes that happens, or we say something that is a standard question that the patient finds might be biased based on their lived experience, there are many ways to restore rapport, such as a clean apology. So we teach those, we do role plays, we do other simulation exercises, and what we expect to do is the exact same process for the skill behavior, identifying behaviors through video analysis, practicing in role plays, and then practicing in a little bit more high-stress simulation settings. My ultimate goal is to have enough effectiveness data that these skills, implicit bias recognition and management, work for the diagnostic process, contribute to diagnostic excellence and equity. Have enough effectiveness data that we can actually change policy at the national level. If you're interested in learning more about our work, we're interested in learning from you. Follow me on social media. I'm on Twitter @CristinaMDNYC.